Hi, is everybody here?
Yes.
Okay, can all of you on your cameras? It's going to be interactive, so I need to see your faces. Tiga, enam, lapan orang je, bukan 10 ke? 8 je, dua kelas. Is this all of you? Yes. No. Is this all of you?
One more, Doctor.
One of you need to answer lah, at least angguk kepala or giling kepala. Be quiet like this, I don't know. Siapa yang present nanti?
Me, Doktor.
Siapa yang present? Hah? Hajar?
Ha. Should we start now or wait?
Tunggu 3 minit ni. Wait for him or her. Him. For another 3 minutes. Hajar, you can share your screen.
Okay.
Orang lagi tu siapa? Dan seorang lagi tu siapa?
Izzati.
Her name is Izzati.
Izzati. Tunggu sekejap. Tapi Hajar kalau nak share screen tu share dulu.
Okay.
Dr. Izzati said she has a problem with her laptop. Her laptop is lagging.
Then use her phone lah. Anyway. Then Hajar, you start.
Okay. Buka kamera. Okay. Okay, so start. Okay, so chief complaint, Nur Izara Balkis, 5 years old, 7 months, malegal, was presented to Accident and Emergency Department of HDA with the chief complaint of diarrhea and vomiting for 2 days duration. Okay, history of present illness. The history was taken from her grandmother. She was apparently well until 2 days prior to admission.
Hajar.
Yeah.
Hajar buat sendiri ke cut and paste dari seniors?
Senior.
Tak, slide ni slide senior ke slide?
Oh, slide sendiri.
Yang kamu. Okay, I don't want to have an English class, but anyway, the first slide tadi, chief complaint tadi. Be very mindful of your grammar. It is a written thing. 5 years, 7 months malegal. That malegal is 5 years and 7 months old. There's a difference, you know. So if it's that sentence structure, it should be a 5 year, 7 month old malegal, so all hyphenated. Okay, if you want to write 5 years, 7 months, then it should be a malegal who is 5 years and 7 months old. With presented to, tak payah was. Right? Nur Izara Balkis, a 5 year, 7 month old Malay girl, presented to A&E department with the chief complaint of diarrhea. Not was presented. Presented is already a past tense. Whenever you have written anything written, please make sure your grammar is not too, ask somebody to double check, okay? It reflects badly on you if there's too many grammar mistakes. One or two tak apa lah. If it's too many, it reflects badly when you present, especially if it's a written report. Understand not?
Noted, Doctor. Okay, should I proceed? Okay.
By the way,
So-
HOPI, please type out history of presenting complaint. Please type out,
Okay.
type out history of presenting complaint. Don't go and write HOPI. This is not your own notes. This is a presentation. What does HOPI stand for? If you Google HOPI, is it a acceptable acronym for history of presenting complaint? No, isn't it? Yes, I'm being nitpicky, but better for you guys to pick up good habits from the beginning rather than try to correct bad habits later on. Continue.
Okay, so the history was taken from her grandmother. She was appearing well until 2 days prior to the admission, when she started to have diarrhea, in which the stool was watery in nature, greenish in color, and it has foul smelling. However, there was no mucus or blood in the feces. There was also increase in the frequency of defecation up to 5 times per day in compared to her normal bowel output of once per day. The volume of the stool was more than normal, which was half a cup for each episode. There was no pain during defecation. There are no symptoms to suggest parenteral diarrhea, such as ear pain, ear discharge, dysuria, hematuria, rapid breathing, cough, or sore throat in this patient. Okay. At the same time, she also experienced vomiting for more than 10 times per day. The vomiting was non-projectile and the vomiters contained fluid and food particles. There was no blood or bile in the vomiters. The volume was about a cup per episode. She also cannot tolerate orally that every time she eats or drinks, she will vomit them out. She also complained of having generalized abdominal pain, which was continuous in nature, but she did not know on how to specifically describe the pain. She was still able to sleep even though she was in pain. There was no abdominal distension. Okay. On the day of admission, her grandmother noticed that she was warm to touch. It was sudden in onset, and the grandmother claimed that it was low-grade fever, despite no temperature documented at that time. It was not associated with shivering or any fitting episode. No medication was given during the symptoms. There was no rash, petechiae, or mucosal bleeding. Okay. Her grandmother also claimed that she appeared to be
Stop dulu. Everybody, camera buka. Everybody, open your camera, please. Okay. Go back to the first part about vomiting.
Okay. Yes.
Daria, one more slide. Aida, is there anything else you'd like to ask?
I think no.
Sorry?
No, I think the history complete.
In fact, anything here that you feel it doesn't make sense?
I think no, but I want to know something regarding the abdominal pain. I want to ask if the pain was relieved when the diarrhea occur or not. So that I want to know if it continues all day long or sometimes it relieved by something something to do lah. The grandmother did what to relieve the abdominal pain.
Excuse me, in fact, we're talking about diarrhea just now, isn't it?
Oh.
What do you think about the history of diarrhea? Your friend already listed the abdominal pain later on. I'm asking specifically about the diarrhea. Anything you want to ask about this slide that you don't quite understand?
I think
Understand that part? There are no symptoms to suggest parenteral diarrhea such as ear pain, ear discharge, dysuria, hematuria, rapid breathing, cough, or sore throat in this patient. Do you understand that part? Yes or no?
no.
Aha. So if you didn't understand, why didn't you ask about it? Naim,
Yes.
do you understand that part? The last sentence.
Parenteral diarrhea is when the infection is caused from outside GI tract, so it comes into the GI tract.
How does dysuria and hematuria, how is dysuria and hematuria related to parenteral diarrhea?
It could be that the patient have UTI first, and then they have the infection inside the GI tract.
How would an infection from the urinary tract get into the GI tract?
In this case, because the patient is a female patient, due to the close proximity between the urinary orifice and the urinary orifice and also the anal orifice, so it can cause the infection can be related.
Which one caused which one now? What are you talking about? Are you talking about the UTI causing the GI problems or the GI infection causing the UTI? If it's the GI problems causing the UTI, it's not parenteral diarrhea, is it?
No, it's not.
Okay, once again, how Hidayah, so can you explain that part? How does the hematuria and dysuria become related to the diarrhea then? How can a UTI suddenly cause parenteral diarrhea?
I'm not sure.
Miss Presenter, Aja, since you presented.
Yes, this what I read from book that diarrhea can be enteral or parenteral, like what Naim said. So from the UTI, it also can affect the GI tract.
So what?
So
now, whenever you copy something, because I know you guys can't clap, real patients because you guys aren't allowed in the ward. But even if you are taking information from a resource, you must double check your information, isn't it? Right? Fine. Sometimes if you can, there is such a thing as parenteral diarrhea, but usually it's associated with respiratory tract infections, right? Pneumonia with parenteral diarrhea, otitis media with parenteral diarrhea, supposedly because the respiratory tract and the GI tract on the upper part of it, they kind of share the same tract, right? So supposedly if you have pneumonia, you kind of follow the bacteria, so you end up having parenteral diarrhea, supposedly lah. But does the urinary tract, in fact, urinary tract have anything to do with the GI? Not really, unless it's what Naim said. In females more likely to get UTI because of the shorter urethral length, right? But it's not, it's diarrhea with UTI rather than UTI causing the parenteral diarrhea, isn't it? So whenever you copy something, make sure what your copy is legit. Don't copy blindly. You guys must think a bit. Yes, I agree. Sometimes when the child has an otitis media, coughing, sometimes at the same time they can also have diarrhea, which they name as parenteral diarrhea. But in children with dysuria and hematuria, do they also get parenteral diarrhea? Unlikely, isn't it? It's two totally separate systems. Unless you're talking about a child being so ill that they become septic and also have diarrhea at the same time. You get what I mean? Izati, why is your view so dark? Huh? Can you on your study lamp or something? Izati? Can you on your study lamp? Thank you. The thing about third year is that you guys are supposed to learn how to take history, yes, but you're also supposed to be able to figure out what is which part of the history is important and which part of the history is less important, and what you need to explain, and what are false negative, what information you need to relay, and what information that you may not get the history from, but you should still relay because it's important for diagnosis. Okay, go next. So diarrhea, basically, first things first is that you have to ask what is normal for the child, right? So diarrhea is increase in frequency and volume, but based on what is normal on the child. So if the child poops twice a day normally anyway, and now still poops twice a day, it's not diarrhea, isn't it? Right? But if the child poops once every 2 days and then now poops twice a day with more loose potty stool, so that's diarrhea. Volume, all right, especially in younger kids, because younger kids are more likely to get dehydrated very much faster, right? The stool itself, how is the stool like? Bloody or not, mucousy or not? If younger age group, whether it's recurrent jelly or not, because you're worried about interception. But this child is 5 years plus, so unlikely lah. Okay, fine. Next. Where was I just now? Naim, Hidayah, Rauda. Anything else you want to ask about the vomiting?
No. No.
Okay, Rauda, what's the significance of having bowel in the vomiters? Why do you need to ask about it?
It's related to like bile duct.
What do you mean it's related to bile duct? What does bilious vomiting indicate?
Sorry.
What does bilious vomiting indicate?
Sometimes in gastritis.
Do you get gastritis? Do you get bilious vomiting in gastritis?
I mean gastric.
Sorry?
Gastric.
Okay, do you know? Yes. Do you know? Yes or no?
No.
Izati? Why do we need to ask for bilious vomiting? Why?
Sign of intestinal obstruction.
Yes, because it's an important sign of intestinal obstruction, right? If the child comes in with persistent vomiting, right, and it's bilious, and the child hasn't passed motion in a while, right, maybe you should be worried about intestinal obstruction rather than acute gastritis, right? So bilious vomiting indicates intestinal obstruction, especially in the younger kids. They tend to put everything into their mouths, right? Okay, so they might have swallowed, you know, those beads that expand in water. You know those beads that expand in water?
Yes.
Those can cause intestinal obstruction. Some of them very colorful, right? Some of them look very pretty, isn't it? Small kids see 2-year-old eat, and then after a few hours, it absorbs all the water in the intestinal tract, and then the kid will get intestinal obstruction. Obviously, there's other reasons for intestinal obstruction, right? But that is also one of the causes, especially with younger kids. Fine. So vomiters also same thing. How many times did they vomit? Bowel stain or not? Blood stain or not? If it's just a little bit, whether it's post-tussive or not, if the child has concurrently, we are not talking about this patient, if the child concurrently have upper respiratory tract symptoms or lower respiratory tract symptoms and is coughing, whether the vomiting is post-tussive, meaning related to the coughs, just once in a while, after bouts of coughing, the kid vomited, right? Indicate a GI problem. Volume about a cup per episode, fine. Cannot take orally, and sometimes she eats or drinks, she will vomit. Okay, fine. Daniel, abdominal pain, what else would you like to know?
Is there any relieving factors of the abdominal pain in this patient?
In this patient, it does not stated here.
So
okay,
when do exactly that she felt the pain? Because in here she stated that it is in the past tense. She was in pain. So when does the pain really stop?
That one also I am not really sure, but it was continuous in nature and it started from 2 days before the admission.
Okay, whenever you have pain, you must ask the patient where it is, right? So it's abdominal pain. A 5 or 6 years should be able to tell you where, but unless it's generalized, so generalized, they might say it's all over. Okay, because you might also be worried about appendicitis. This just because the kid landed in the pediatric ward and not the surgical ward doesn't mean it cannot be a surgical cause, right? Because you're dependent on the casualty medical officer to send the patient where the patient gets admitted, isn't it, right? So early appendicitis can get and generalized abdominal pain. Sometimes we can also get symptoms which are AGE-like, isn't it, right? But not up to this extent. But anyway, so where it is, you need to ask, how is the pain like? Is it colicky in nature? Is it continuous? Is it relieved by anything? Is it relieved after the child defecates? You guys know what intersusception is or not? Intersusception, do you know what it is? Yes or no?
No.
When the intestine overlaps with itself.
What intersusception? Sorry?
Or when
Naim,
the intestine,
Naim,
when
I
the
think my
intestine overlaps with itself.
yeah, so it's basically the intestines telescoping onto each other, isn't it? Right? You know those type of telescope where you can pull and then you can close back. So that's what happens in the intestine. So usually you see this in kids who are just starting to wean. So those that are roughly about 8-9 months up to about 1 year old, the most commonly lah, right? So in those type of cases, the kid gets pain when the child wants to, when it's telescoping, right? So, and then they will, if you read, typically they'll lift out their legs up and then like mengerang for a while, and then when the telescope relieves itself, sometimes it goes in and out, right? When it relieves itself, the kid will feel better. So that's the thing that you ask, whether when the child try to poop, he mengerang, and after that it's okay, right? So that is intersusception, but that's in a younger kid, not in a 5-year-old usually. Still able to sleep even though she was in pain. It was not fine. Okay. Daniel dah hand tadi. Back to Aida. Aida, just based on this, what else would you like to ask? Broad topic. What else would you like to ask? Just based on this, without going further yet.
Maybe about since
Sorry?
or maybe eating outside respective
Okay, you want to go on to risk?
Yeah.
Okay, how risk factors also. Okay, fair enough. Outside food. Azaim. Ifat, what else would you like to ask apart from risk factor? Something more relevant now, right now.
I don't know, but I same with Ida. I also want to know regarding if there is any eating outside or if risk factor.
Not risk factor. The child is vomiting, the child is having diarrhea, the child cannot tolerate orally. So what else would you like to ask?
Dehydration.
Aida, is your name Ifat?
Okay.
I want to ask if
Sorry,
if this patient is still can do daily activities like playing or not, because if there is because due to the vomiting and diarrhea many times per day, this can cause severe dehydration. So this patient can be lethargic and cannot cope well.
Okay, so the child's general condition, right? So whether the child is active as usual, whether the child is a little bit tired and sleeping most of the time, right? Is the child still able to play in between bouts? Fine. So that goes towards your assessment of a hydration status, isn't it? Right? So Akila, what else can you ask? If you want to assess the hydration status.
Yes.
Sorry?
Is there any episode of loss of consciousness or a decrease in frequency of urine output?
Or what? Sorry?
Or severity of dehydration?
How would you ask? History. How would you ask?
Is there any episode of loss of consciousness or drowsy?
Okay. That goes back to general condition, isn't it? Something else. What else would you ask? As part of the assessment of the hydration status.
What about rapid breathing, shortness of breath?
Rapid breathing.
And then the child can become irritable
that goes back to general condition, isn't it? Right? General condition and neurological status, fine. What else? You were saying, what else? What else? How would you try to assess the hydration status based on history? What else can you ask about?
Is it reduced in urine frequency? Oliguria.
So you're going to ask about urine output, isn't it?
Urine output, yes.
Right? Whether the child is, what is the child still peeing the normal amount, or is the child more, tell you lah, right? If it's a child in diapers, then it's a bit more difficult because sometimes you have loose watery stools. The loose watery stools will be mixed together with the urine or the lack of urine in the diaper, so it's very difficult to tell. But if the child is toilet trained, then you can ask about urine output, right? Naim already answered so many. Hidayah, what else can you ask? If in regards to status, so already general condition and alertness, mental status, already urine output. What else in relation to hydration status?
Increase thirsty. Sebab if the patient drinks eagerly, or the frequency of drinking.
Okay, whether the child is thirsty or not, dahaga ke tak, right? How often does the child need to drink? But then also that you need to ask lah, but obviously in this patient, the child is vomiting. Can the child tolerate fluid at all or not? Huh? Hajar, can the child tolerate any fluid at all or not?
Yeah.
Not
She
sure.
cannot tolerate orally because she will vomit it out. Sekejap.
Little bits or sips of water langsung tak boleh. So for 2 days, no
she
water at
cannot
all.
tolerate orally.
For 2 days, no
For
water
2
at
days,
all.
I'm not sure, but cannot tolerate orally. I'm not sure about the water.
Right.
Drink will vomit also.
No, don't assume when the parents say cannot eat everything will muntah. That means the child has been without any liquids for 2 days. Maybe then you need to ask whether she's been like taking sips or not, isn't it? Right? Can she like tolerate small bits of sips of fluid? If this was a baby, 2 days without any fluids, the child will be very dehydrated already. Right? Okay, next slide, Hajar, continue.
Okay.
Ada tadi mana warm to touch tadi?
Apa dia?
The slide with the warm.
Ni?
The slide before that, yang warm to touch now. Claim it was low grade fever despite no temperature or female. Even during the symptoms. Fine. Next.
Okay. So her grandmother also. Okay. Grandmother also claimed that she appeared to be lethargic, thirsty, and less active since the onset of the symptoms. She preferred to lie down on the bed rather than playing. She had poor oral intake, but there was no loss of weight. There were also dry lips and sunken eyes noted by her grandmother. There was also decrease in frequency of urination. Okay, so at first, her parents did not bring her to any general practitioner or clinic because they thought the symptoms will subside spontaneously. However, on the second day of the symptoms, her parents were worried about her condition as she looks pale and weak, thus decided to bring her to A&E department of HTA.
Ya, nak tanya jap. The history was from the grandmother, right?
Yes.
His grandmother, right? The grandmother stay with the kid, is it? Or the grandmother take care of the kid while the parents are working?
Because her mother have like outstation, so she stay with her grandmother.
Oh, okay. Then cannot be the parents, right? At first, the parents?
I think it's
Kalau
first
mak dia
day.
kalau mak dia pergi kursus, jadi budak ni tinggal dengan siapa sekarang? Masa sakit ni?
Her grandmother.
Okay, then why the story about the parents down there?
Sekejap.
So dia ke tinggal dengan ayah sekali? Kalau ayah, then her father, isn't it?
Ayah dia ada sekali.
Right,
Ayah
mak
dia
je kan
sekali.
pergi kursus. So it wouldn't be your parents, right?
Yeah.
Inconsistent, right? Realize now your story inconsistent. Because you're telling me that the mother went to pergi kursus, right? If her mother pergi kursus, then how come the story of about her parents pula? It wouldn't be her parents, it would be her father, isn't it? It's something small lah, but it's inconsistent lah. Faham tak?
Faham.
So the history from the grandmother, fine. So the whole family stays together, is it? Tak tahu.
Yeah.
Can I just ask, the presentation by your seniors, yang ni case senior kan? Is a case write-up or what?
What? Apa dia?
This case is a case write-up or how? Yang dari senior ni?
Case write-up.
When you guys need to write case write-ups, right? Always make sure that somebody else reads it before you hand it in. Right? Like you buddy read with somebody lah, isn't it? Make sure that if the story is inconsistent, at least try to straighten it out lah. Alright? This is like, you don't just assume things, right? I mean, if the story doesn't make sense, you must clarify lah. Next, for you guys' sake, if you guys got case write-up, make sure after you finish, before you hand it in to your lecturer, ask your friend to read and see whether the story makes sense to your friend or not. Right? Also, to check for typos and grammars and stuff like that also lah. Because sometimes when it's inconsistent, it's very difficult. It's like when you read a storybook and then the plot doesn't make sense, you get a bit irritated, isn't it? Right? Next.
Okay. So upon further questioning, her father and little sister also have diarrhea 2 days before the onset of the symptoms, but they did not seek any treatment and the symptoms resolved by themselves. There was no history of traveling or eating outside food or raw food. She did not live in dengue-prone area, and there was no recent dengue case or fogging activity in the neighborhood. There was no significant recreational history or rat infestation. So that's
Next.
okay, so systemic review, general, she had fever, loss of appetite and lethargy, but there was no loss of weight. Gastrointestinal system, apart from symptom described in history of presenting illness, she did not have any constipation, jaundice, adrenophagia or dysphagia, and any changes in frequency of passing flatus or flatulence. Respiratory system, there was no history of shortness of breath, cough, runny nose, rapid breathing or noisy breathing. Cardiovascular system, no chest pain, autopnea, paroxysmal nocturnal dyspnea or ankle swelling. Genitourinary system, there was no frothy urine, hematuria or dysuria. Neurological system, no history of eating episodes, headache, neck stiffness or confusion. Musculoskeletal system, no arthralgia, myalgia or bone pain. Should I proceed? Okay. For past medical surgical history, when she was 4 years old, she was hospitalized in Hospital Terendak Camp Melaka for 2 days due to the same symptom. But her grandmother was unsure about the diagnosis at that time. Otherwise, she had no known chronic illness such as bronchial asthma, and there was no past surgical history. Drug history. She is currently not on any medication or supplement. The patient had no history of taking antibiotics in a few days before the onset of diarrhea. She had no known drug or food allergy. Okay, birth history, antenatal was uneventful. Her mother does not have any gestational diabetes mellitus or preeclampsia during pregnancy. Intrapartum, the child was delivered at term via emergency C-section at HDA due to fetal distress. Her birth weight was 2.8 kg. There was no complication perinatally. Postnatal, there was no complications such as postpartum hemorrhage. However, the child had neonatal jaundice on her first 2 days of life. It has resolved spontaneously and phototherapy was not needed. Okay. Immunization history. The child is vaccinated according to the National Immunization Program and does not have any side effects following the injections. Okay. Nutritional history. She was exclusively breastfed until 2 months old. After that, she was also alternately given formula milk. She was breastfed until the age of 2 years old. She had started weaning at the age of 6 months old, whereby she was given porridge mixed with blended vegetables. She started to consume adult diet at the age of 1 year old. Currently, she is eating normal adult diet such as rice, noodles, chicken, meat, fish, vegetables, and fruit. Okay, developmental history. The developmental milestone of this patient is normal as expected and correspond to her age. Gross motor, she skipped the phase of crawling. She was able to cruise around the furniture at the age of 10 months and walk steadily at the age of 11 months. Currently, she can run and skip on both feet. Fine motor, currently she can draw man and house. Speech and language, she started to use the word mommy and papa at the age of 1 year old. Currently, she can speak in long sentence with fluent conversation and she knows name, age, color, alphabets, and numbers. Social, she was able to drink by holding cup using her 2 hands at the age of 1 year old. She was by at the age of 3 years old and pulls off some clothing at the age of 4 years old. She went to preschool and started to play with her friends at the age of 4 years old. Currently, she can attend own toilet needs and undress independently. Okay. Family history, she is first child out of 2 siblings. She has a younger sister who is 1 year, 11 months old. The sister is healthy, but she also had diarrhea 2 days before Izara developed the symptoms. Her parents are both healthy with no medical illness. There is no history of malignancy runs in the family. Social history, her father is an army at Terendak camp. Her father is a non-smoker, but her uncle, who is also currently living in her grandmother's house, is a smoker and he smokes in the house. Her mother is a nurse in Hospital Melaka. The monthly income of the family is about 5,000 ringgit. Before this, she stayed with her parents at Melaka. From the past 6 months, she lived with her grandmother at Bukit Sagu as her mother is attending a course at Kelantan. She is currently living in her grandmother's house, which is concrete and has clean water and good electrical supply. She is studying in a tadika at Bukit Sagu. That's all for history.
Summarize the history.
What?
Ajar, summarize the history.
Okay.
Summarize.
Chapter. Oh, summarize. Okay. Okay, so Nur Izara Balkis, a 5 years, 7 months old Malay girl, was presented with the chief complaint of watery non-bloody diarrhea and vomiting for 2 days duration associated with low-grade fever, lethargy, abdominal pain, and reduced oral intake. Her father and little sister also have diarrhea 2 days prior to the onset of her symptoms. No history of traveling to endemic area or eating outside.
Okay, fine. History clear. Just based on your history, what's your differentials right now? Just based on your history. Yeah. Just based on your history, what do you think the child has?
I think for the provisional diagnosis, is acute gastroenteritis with moderate dehydration.
Why moderate?
Because her grandmother noticed sunken eyes, and also she cannot tolerate food orally, and also urine output is reduced, and she is thirsty and also less active.
When do you mention that she's thirsty?
Apa dia tak tahu?
You didn't, right?
What?
You didn't mention that she's thirsty, right?
Ada. Yes. Lethargic, thirsty, and less active.
Okay, fine. Any differentials?
Okay, for differential, second one,
then why sorry? Okay, what's your differentials?
Differential. Okay, dengue. Dengue fever with warning signs.
What's the points for? What's the points against? Just based on
for history, because she had diarrhea, vomiting, fever, lethargy, and restlessness, less active, and also sign and symptom of dehydration. But for points against, because there is no fogging activities and not endemic area for dengue, and no history of dengue fever around the neighborhood, no rashes, and no joint pain or muscle pain.
Go on to your physical examination.
Apa dia, doktor? I cannot hear.
Sambung, physical examination.
Physical examination.
Sambung.
Okay. Okay, physical examination. It was done on the day of admission in ward. She was lying comfortably on the bed with her grandmother at her side. On general inspection, she was conscious and alert. She was not in pain or respiratory distress, but she looked lethargic. She is a medium built girl with no muscle wasting. There was no dysmorphism noted on the chart. On peripheral examination, there was no finger clubbing, peripheral cyanosis, or flapping tremor. The capillary refill time was less than 2 seconds, but the peripheries were cool. The skin turgidity was normal. There was no rashes or bruises present. There was no jaundice or pallor. The eyes was slightly sunken. The oral hygiene was good with no dental caries. The lips were slightly dry and the tongue was coated. The mucous membrane of the mouth was moist. There was no central cyanosis. No lymphadenopathy, and no lower limb edema noted. Okay. Vital signs, pulse rate 120 beats per minute, good volume and regular.
Go back to the slide just now. Hajar, go back to the slide just now.
General examination.
Okay, tadi Rhoda kan? Hidayah dah kan tadi? Rhoda. Capillary refill time was less than 2 seconds, but the peripheries were cold. Does that make sense? In terms of assessment of hydration and assessment of the circulatory system, does that make sense? Capillary refill time was less than 2 seconds, but the peripheries were cold.
No.
Why doesn't it make sense? Why doesn't it make sense? You don't think it makes sense? Okay, fine. But why doesn't it make sense? I'm forcing you guys to think lah, please lah. Like, jangan, like, don't copy bulat-bulat and don't take things at face value, right? Think. Why doesn't it make sense? Fine, you say it doesn't make sense, fine. But why doesn't it make sense?
Because of the blood volume, I think.
What do you mean because of the blood volume? If the capillary refill time is less than 2 seconds, what do you expect the peripheries to be?
Less than
Warm
2
or
seconds.
normal, isn't it?
Warm, yeah.
True or not? Right? Most of the time, if you say capillary refill time is less than 2 seconds, it just indicates that perfusion is good, right? If perfusion is good and your capillary refill time is less than 2 seconds, the peripheries shouldn't be cold. Because we are talking whenever we are talking about this, right? CRT less than 2 seconds, peripheries were warm. What else goes together? Pulse volume and heart rate, isn't it? Right? All those goes together because that's an assessment of the circulation. True or not? So if capillary refill capillary refill time is less than 2 seconds, you would expect the peripheries to be warm. Now, I'm not saying that you need to lie if the peripheries are really cold, right? I'm not saying that. Honestly, expect the peripheries not to be cold. Maybe it's cold, maybe because dia baru basuh tangan, right? Or maybe maybe she just held something that was cold, baru lepas minum Milo ice or something, and she held the cup, and then after that her hands felt cold, right? But usually, if your capillary refill is less than 2 seconds, your peripheries should be normal, isn't it? Right? So that's why.
For the hydration, it's more reliable for based on the capillary refill time, right?
Sorry, I don't understand you. Can you repeat your question?
Means that if we want to assess the hydration status or the secretion status, it's more reliable to the capillary refill time rather than
you don't take one thing and you don't just simply take one aspect on it and say, oh, this is less than 2 seconds, so the circulation must be good. No, it's an assessment as a whole, right? So if your whole capillary refill time is less than 2 seconds, your heart rate is 80 beats per minute and pulse volume is good, even though the peripheries might feel a little bit cold, it actually still indicates that perfusion is still good, right? Then you have to ask yourself why the peripheries are cold. Isn't it? Right? It might be a lot of reasons, might be the area itself, the air conditioning was too hot, too cold, then the child felt cold, or the kid just washed their hands or something. But you have to take everything as a whole. You cannot just, this is going back to Rauda's question, you cannot just say capillary refill less than 2 seconds, so definitely the child's circulation is good. You have to take everything into account.
Okay.
But anyway, that sentence kind of don't really make sense, because if your capillary refill time is less than 2 seconds, periphery shouldn't be cold. Some more, if you're talking about hydration status, you should also group the heart rate and the pulse volume here. I know it's part of your vital signs, right? But because this child you assume has AGE, right? So the most important thing is hydration status, right? So you group the hydration status information together because it makes more sense. You get what I mean now? Because your history, whenever you present, it depends on, yes, you follow a certain formula, right? But you can also modify it to make it make more sense based on what you think the child has. Well, we know this child has AGE, so what's the most important thing is the hydration status. So you should group all the hydration status things together. So this child's, the other thing is the comfort. Okay, that's another thing. So you should group, I think this child has currently has a normal hydration status because capillary refill is less than 2 seconds, her peripheries are warm, pulse volume is good, she is not tachycardic with a heart rate of 90 beats per minute, right? Her mucous membrane is moist, and that's about it, isn't it? Skin turgor is normal. So you group it together because this child has persistent vomiting and diarrhea, and that's the thing that's most important in the assessment of this child. Okay, Izzati's laptop just blanked out, I think. Anyway, understand not? So if like the child has pneumonia, right? The child's symptoms, if the child's symptoms was respiratory related. So when you present your physical examination, are you going to present your abdominal findings first? No, isn't it? You're going to present your respiratory findings first, isn't it? Right? So you group everything together. This child is, even in your general examination, you would talk about, you would place emphasis on the respiratory symptoms, respiratory findings first. You would say that this child is pink under room air, not tachypneic with a respiratory rate of 20 breaths per minute. You would say that first before you talk about hydration status, because this child came with respiratory symptoms, and that's the main thing, isn't it? Right? I'm not saying don't present everything else. I'm saying that you present based on order of importance. You get what I mean now? Anggo or Giling? I don't know. If none of you want to want to say anything, then at least you could say, you to do is Anggo or Giling. Understand ke tak?
Yes.
Right. So when you present, you think first what is the most relevant to my patient, right? And you structure it in such a way that you present the most relevant findings. Basically, in the beginning lah, because that's the most important thing, isn't it? Right? It's like I ask you. It's like if I ask you, do you like the color purple? And then you answer, oh, red is not my favorite color. Blue is not my favorite color also. But then somehow when you add blue and red together, it makes purple, right? Oh yeah, so yeah, purple is my favorite color. It's like, you get what I mean? It's like people, I just ask you, is your favorite color purple? Like, yes, purple is my favorite color. You don't need to get to your point, right? But anyway, in this case, the hydration status should be chunked together, and also CRT less than 2 seconds and peripheries will cold kind of don't go together, right? Peripheries were cold. When you tell me someone's peripheries are cold, I expect from a medical point of view, I expect really cold, pucat already, you know, capillary refill also probably more than 2 seconds, right? Not your cold, your biasa type of cold. So like, also lying comfortably on the bed. Try not to say lying comfortably on the bed, because comfortable is a very subjective thing. All right, so what's comfortable for you may not be comfortable for another person. It's much better for you to say things that can be objectively grouped together. So she was lying fine. She was lying on the bed with her grandma at the side. But the more important thing is that she was conscious and alert. Right? She was conscious and alert, lying on the bed with her grandmother on the side. Right? Don't say comfortable or not, because sometimes you guys get so used to saying comfortable when the child is not comfortable. You just blurt out the word comfortable just because the child doesn't look like the child is in pain. Right? So try not to use it. Next page.
Okay. Vital signs, pulse rate is 120 beats per minute, good volume and regular rhythm. Respiratory rate 20 breaths per minute, normal. Blood pressure 84/50 mm mercury, normotensive. Temperature 37.6 degrees Celsius, slightly high. Okay, anthropometric measurement, weight 19 kg at 15 centile, height 116 cm between 75 to 19 centile. Okay, so for abdominal examination, inspection, the abdomen was not distended, the umbilicus was centrally located and inverted. There was no surgical scar, visible peristalsis, visible pulsation, and dilated vein noted. Palpation, there was generalized tenderness of the abdomen. There was no guiding or palpable mass. Liver and spleen were not palpable. Kidneys were not palatable. Percussion, shifting dullness was negative. Liver span was 5 cm. Throat space was resonant. Auscultation, bowel sounds were heard and the frequency is normal. No aortic or renal bruit. The perianal examination was not done as the patient did not give her consent. Okay, cardiovascular examination. Inspection, there was no chest deformity, scar, visible pulsation or dilated veins. On palpation, no trills and parasternal heave. The apex beat was palpable at 4th intercostal space mid-clavicular line. Auscultation, first and second heart sound were heard with no murmur or any added sound. Respiratory examination, on inspection, the chest was moving symmetrically with respiration. There was no chest wall deformity, no scar, and no usage of accessory muscles. On palpation, trachea was centrally located and the chest expansion was normal and equal bilaterally. All zones were resonant. On percussion, bilaterally. Auscultation, the air entry was good and equal bilaterally. Vesicular breath sound was heard with no added sound. Tactile frothitis was not done. Neurological examination, no wasting of circulation noted on both upper and lower limbs. Tone, power, and reflex were all normal on both upper and lower limbs. No ankle clonus. Babinski reflex showed going down. Sensation was intact. Yeah. So for summary of examination, there was moderate dehydration as evidenced by lethargy, slightly sunken eyes.
Your
Yes.
moderate dehydration is based on what? Based on admission or based on when you examine the child?
Because the examination is on the day of admission.
Okay, so if then you need to specify that with moderate dehydration on admission, because your physical examination currently, does it show moderate dehydration, yes or no?
Not
no,
really.
Okay. Go back to your physical examination.
But the eyes were sunken.
Breathe refill normal. Pulse volume good.
So more to history.
Do you mean the tongue is coated but the mucous membrane of the mouth was moist? Also, I didn't notice your second point. Try not to use the word lethargic because lethargic is used in the assessment of a person's neurological status. So if you say lethargic, it means that the child is still arousable, but it's not the same as if what you're trying to say is that the child looks tired, fine. Say tired, don't say lethargic, because later on when you do assessment of neurological status, lethargy comes under one category, right? So if she is alert and conscious, in terms of neurological assessment, she cannot be lethargic. You get what I mean? Not? Do not use it interchangeably with being tired looking, nampak macam letih. Right? Even though I know lethargy in the English language, it also means that the child is tired, right? child is tired and sleepy. The problem with this is that because you also use the term lethargic as a specific term in the neurological assessment, right? So the fact that it's used as a specific term in the neurological assessment means when you're talking to a person who is medical based, when they hear lethargic, they think that the child's conscious level is not 15/15. You get what I mean? Because we kind of forgot that lethargy has also an English meaning to it. Understand that? Right? So try not to use the lethargic. If the child looks tired, then you say the child looks tired. But what's important is that the child is alert and conscious. Right? You can be tired, but you can be alert and conscious, right? But when you're lethargic, sometimes your GCS is already 14/15. That's what I'm trying to get at. So because we are doing medical things, whenever you say something that have both a medical and an English meaning, right? Default to the medical meaning. Default to the medical meaning, right? So don't make it sort of where there's one word with dual marker and you have to figure out which meaning you're trying to use, right? Because if the child is alert and conscious, you cannot say that the child is lethargic based on neurological assessment. So if you say that the child looks tired, fine. Don't say the child looks lethargic. That's one.
Doctor, if ill looking, can we use the
Sorry?
term ill looking?
Huh?
Can we use the term ill looking?
Also, that would cause confusion. If it's 2 a.m. in the morning and then somebody calls me and say the child looks ill, I'm going to get up and run to the ward. Right? What is more important is that whether the child is alert and conscious or not, whether GCS is 15/15 or not. Right?
Okay. Okay.
If you say somebody is ill looking, if somebody calls you at 2 a.m., you tell me that child looks ill looking, I assume the worst. Also, that's why ill looking is not really a good term to use also because it's very subjective. Looks quite sick. Ill looking. Ill looking, I would think that child very severely sick already. But that is better than saying lethargic lah, at least lah. If the child really looks ill, meaning memang dah macam though cannot get up, then fine lah, fair enough. You can lah, but I don't recommend it unless the child really looks like that. Then yes, the child looks ill looking, fine. But if the child is alert and conscious, just looks a little bit tired, I wouldn't say that the child is ill looking. If the child terlantar kat katil, memang nampak tak bermaya sangat, then fine, ill looking, right? It depends on what you interpret. But lethargic, I tend not to use at all, unless I really mean that the child's GCS is not full and the child really looks like it's very difficult to arouse, right? So try not to. Heart rate 120, slightly tachycardic for a 5-year-old. Temperature is 37.6. How can your wet mucous membrane? Now the problem here, where is it? Okay.
Yeah.
Eyes are slightly sunken. Moderate dehydration. I would veer towards mild dehydration rather than moderate dehydration on examination here, right? When you present, be very sure, especially with AGE, when you give the diagnosis, mention whether the dehydration is on admission or the dehydration is currently during examination. It makes things clearer. But if you clock on that day and you're presenting on that day, I would expect the current condition rather than the condition on admission admission because you did not examine the child on admission. You examine the child now.
Doctor, mute, you mute your mic.
Where was I before the connection disconnected? What part you guys heard me mumbling about this one?
The diagnosis must be on current.
Yeah. If you want to qualify, because it's AGE, you guys always get confused. If you want to say that she has moderate hydration, then you must say that moderate hydration when, but currently her hydration status is normal. The reason why is because if you are doing a long case and you are examining the patient, are you examining the patient during admission? No, isn't it? We want to know whether you know how to assess the child when you are doing the examination, right? So if you want to mention that you think that the child was moderately or severely dehydrated during admission, fine. You can just say that this is a child with AGE with severe dehydration. However, currently, during my examination, her hydration status is normal. That's how you phrase it, okay? Just continue. No questions, then continue.
So the summary. So this is provisional diagnosis, acute gastroenteritis with moderate dehydration, but currently during the examination, the hydration status was normal.
Mildly dehydrated lah, fine lah, because dry, coated count, slightly tachycardic. You want to say more dehydration, fine. Slightly sunken eyes, right? Ajar.
Yes, slightly sunken eyes.
Okay, then.
Okay, so for differential diagnosis, the first one is
right. Habis lagi. Now, you say it's AGE, right? Why is the history, no history of traveling or eating outside a point against? Why is there a history? Why is there a point against? Tadi, because
I think it's infected by bacteria or virus.
Do not confuse AGE and food poisoning.
Food poisoning.
Right? Food poisoning is when you eat something that's either gone bad or whatever it is, and yet food poisoning, start vomiting and silent diarrhea. AGE is usually infective, isn't it? AGE is most commonly caused by what? EFAT. Is it viral in origin or bacterial in origin? EFAT. AGE, mostly bacterial or viral?
Viral.
Yes, it's mostly viral, isn't it? What in the history just now, Akila, what in the history just now that shows that most likely this is AGE, just now in the history. She didn't write it here.
Low grade fever.
No. What else in the history that shows that it's most likely AGE?
Because the sick contact, the father and the sister also had the same symptoms.
Sorry?
The father and the sister also had the same symptoms.
The father and sister had the same thing 2 days ago, right? Correct or not? AGE is infective, isn't it? That is why when a child in a daycare gets AGE. A few days later, 10 of her friends in the same daycare also gets AGE. Isn't it? Rotavirus, right? In the daycare age group, isn't it? Right? AGE, history of eating outside, doesn't matter. Because it's usually viral in origin, isn't it? Right? It's infective. So the brother and the sister and the father had it 2 days prior to her having it, and now she's having it. So most likely it's an infective thing, so it's probably AGE. History of outside food is related to food poisoning, isn't it? Right? Abdominal pain, low gut. Oh, she wrote that father and sister, little sister also have diarrhea. Points 4. Points 4 would be just low-grade fever with vomiting and diarrhea, isn't it? Full stop. And also father and sister also having diarrhea. That's point 4. Less active, thirsty, lethargic, sunken eyes, tachycardia, cold extremities, dry lips. Those are not points for it being AGE. How to tell this? How to explain this to you guys? Okay. Tachycardia, sunken eyes, cold, not sunken eyes, tachycardia, cold extremities, it's just a sign of poor perfusion, right? So it cannot be a point for AGE because anybody with poor perfusion will also have those things. It's AGE because the child has low-grade fever, the child has vomiting with diarrhea, and the father and the sister has similar symptoms. This is like how do I explain it to you guys? If the child is dehydrated, you can get the last 4 things that listed there, right? But it doesn't mean that the dehydration is caused by AGE. You cannot say that it's AGE because of the signs of dehydration. You say it's AGE because there's diarrhea and there's vomiting. If the child has pneumonia, the points for it being pneumonia because the child has symptoms of pneumonia, which would be fever, cough, and maybe productive sputum, right? But you cannot say that the points for pneumonia is because the child is tachypneic. Because tachypnea can be caused by a lot of other things, not related to pneumonia. Oh, do you guys get it now? Why I say the last 4 is not why the reason why it's not AGE? Do you understand why not?
Yes.
Do you understand not why I say the last 4 bits of this is not a reason why it's not a point for it being AGE?
So only list the specific symptom.
Yes, you need to specify the specific symptoms. Sunken eyes, tachycardia, cold extremities, and dry lips and bloated tongue is a sign of dehydration. But it's not necessarily a sign of AGE, right? It can be a sign of severe starvation, right? It can also be a sign of severe starvation. It can also be a sign of somebody who has anorexia, but it's not necessarily just a sign of those 2 things, right? So if you point 4 must be symptoms which is related specifically to that condition. So examples would be it's nephrotic syndrome because the child is edematous with reduced urine output and bubbly urine, right? Points for dengue, it's because the child has fever with rash. But you cannot say that the child has dengue because the child is tachycardic. You get what I mean? Right? Just because the child is tachycardic, it doesn't mean it's dengue. It's probably dengue because the child has fever and the child has rash together with the fever. Right? But that's how you do points for and points against. You get it not? You guys, because I always see this. I always see this when we ask you questions like, why do you think the child has pneumonia? I think the child has pneumonia because the child is tachypneic, which is not really true because tachypnea is too broad. The child has pneumonia because the child has fever associated with cough and sputum, productive sputum. Okay, if you understand, then just continue. Next one.
Doctor, so for provisional diagnosis, do we need to include the dehydration status or only just put the EGE?
No, well, provisional when you come up with a diagnosis, you just need to say why you think it's that diagnosis and why you think it's not that diagnosis. That is all. You just need to say why do you think it's this diagnosis and why do you think it's that diagnosis. That's all. As long as you can justify your diagnosis and it makes sense, nobody's going to say you're wrong, but you must be able to justify it. Right? People can tell you it's unlikely lah, but like if you said this was food poisoning, your differential was food poisoning, and you justify it by saying because food poisoning, the main symptoms is diarrhea and vomiting, I'm not going to say you're wrong because that kind of makes sense, isn't it? But it's most likely not because timeline, she only had it 2 days after the other two people had it. Also, no history of eating any other outside food, right? Even if I wanted to say that, if you wanted to say that this is dengue with warning signs or so, it is not wrong because you can justify yourself by saying that the child has fever and dengue with warning signs would sometimes present with abdominal pain, vomiting, and diarrhea not so much, but sometimes yes. But there's a lot of points against it, meaning fever duration too short, it's just day 2, right? No rash, but what? No rash. No history of fogging. No history of bleeding, right? Clinically also, the child's circulation seems quite good, even though the child is just mildly dehydrated. So that's unlikely to be dengue fever with warning signs. As long as you can justify yourself, it's fine. But make sure that your reasons make sense lah. Right? And make sure that you list the ones that are more likely first before you list the ones that are less likely lah.
So this is the differential diagnosis. First one is dengue fever with warning signs. So points 4 would be fever and then diarrhea, vomiting, and also forgot to include the abdominal pain. Okay, and then for points against, no history of fogging activities, not in endemic area, no other neighbor have dengue fever, no rash, no mucosal bleeding or any joint pain.
Next.
Okay, and then second one, leptospirosis. Points 4, diarrhea, vomiting, fever. Points against, no rat infestation, no significant recreational history, no jaundice, no joint or muscle pain. And then the third one, parenteral diarrhea. Points for diarrhea, vomiting, fever, and poor oral intake. 4 points against, no UTI symptoms like dysuria or hematuria.
We just talked about this just now, isn't it? The UTI thingy. Can you like mention that part? Second part lah, second and third part. The first one just now we just at the beginning I was kan? Just read the second and third one. No, I mean read the second and the third point again because the first one.
Oh, okay, UTI tu eh. Okay. Second, no ear discharge or ear pain to suggest otitis media. No cough, shortness of breath or wheezing to suggest respiratory system infection.
That's all?
The last one, I want to include the acute appendicitis. Points for vomiting, diarrhea, and also abdominal pain. Fever, generalized tenderness upon palpation. Points again, of skin sign was negative, no sign of UTI.
Why does appendicitis have signs of UTI?
Okay.
Hajar, you're talking acute appendicitis, right?
Yes.
You're talking about acute appendicitis, right? What points against is no sign of UTI? What does acute appendicitis have to do with UTI?
Or skin sign.
No. What does acute appendicitis have to do with UTI? Your points against the second one.
I think maybe the UTI can also affect the appendix infection, or is it? I'm not really sure.
I mean, acute appendicitis is acute appendicitis, right? Why what your senior man was no urinary signs, because sometimes it might have a bit of frequency. Rather than, because you're talking about acute appendicitis, why is there a UTI there? Unless you're talking about no urinary signs, no urinary symptoms such as frequency lah. Isn't it? Also, the only time UTI can cause, usually if UTI causes diarrhea, it's in babies, very young babies, not for a 5-year-old kid. Going back to the UTI and the diarrhea thing. Anyway, I think might be no urinary signs rather than no sign of urinary tract infection. It's a different. It means different things, right? No urinary symptoms means things like frequency, dysuria. Okay, so sometimes in appendicitis there might be a bit of frequency and dysuria. Fine, but then if you're saying but no sign of urinary tract infection, yes, you're talking about the same symptoms, but in this case, it's not a point against acute appendicitis. Right? Because what specifically you're talking about is the symptoms, not the diagnosis of a UTI. UTI is the diagnosis. Generalized tenderness upon palpation can be early appendicitis, especially in young kids. Yeah, so it's a 0.4. Yes, true, fine. Vaccine sign was negative. Oh, is that all?
Yes.
Now, AGE, the important thing for you guys to know is how to assess hydration status based on symptoms and also for signs, right? And then you need to know what plan A, plan B, and plan C is. So plan A is basically oral hydration, isn't it? And then roughly just know about the regimes. Now go on to investigations. Tadi stuck kat mana? Aida, if you were the person seeing, what would you order? What investigations would you order?
Maybe blood count to
Why?
check for leukocytosis infection.
Signs of infection. So what specifically are you looking for?
Increase white cell count.
Okay, if it's bacterial, then you may have increase in white blood cell counts, fine. It might be normal in AGE. The white blood cell might be slightly reduced if it's viral, because all viral infection causes your white blood cell to drop, but it might still be normal, isn't it? What else in the white blood cell? What else in the FBC would you like to look at? Hidayah, what else in the FBC you like to look at?
Look for lymphocyte.
Okay, going back to whether it's viral or bacterial infection, fine. What else? Now your differential was dengue, right? So you will look for associated changes with dengue, isn't it? You want to see whether white blood is low, whether there is thrombocytopenia or not, right?
Look for
Because one of the different
or hematocrit.
Yes, you want to look at hematocrit for two reasons. One, because your differentials was dengue. Two, because if the child is dehydrated, your hematocrit will go up or normal or go down. Which one? Show me. Up. Normal. If you are dehydrated, what happens? Hematocrit goes up or goes down or same?
Up.
How many people? Up, isn't it? If you're dehydrated, that means your blood becomes more concentrated. That's why your hematocrit will go up. It's the same thing with dengue, isn't it? Hematocrit goes up because intravascularly, the people with dengue, the patients with dengue are intravascularly depleted, right? The blood within their vascular system is hemoconcentrated. Okay, so done with FBC. Naim, what else investigations would you like to do?
I would like to order for renal profile to assess the severity of the dehydration.
Fine, so specifically look at the urea and the creatinine, right? So if the child is dehydrated, the urea usually will go up. Creatinine may or may not go up, depending on how dehydrated the child is and whether there's renal damage or not. The urea will go up first. The other thing is to look at the electrolytes, right? If the child has hypernatremic dehydration, then sometimes you're gonna under assess the degree of dehydration when you're doing your physical examination. Also, if the child is persistently vomiting, you're worried about what? The potassium will drop, right? Hypokalemia, right? So sodium also might pay attention. Sometimes the kid can get hypernatremic dehydration. If the child gets hypernatremic dehydration, when you rehydrate the child, you must rehydrate over a longer period of time. You cannot rehydrate the child too quickly because of something which I want you guys to look up. Why you should not rehydrate a child with hypernatremic dehydration too quickly. Go and look it up, okay? That's your homework. Okay, so Daniel, what else would you order? So hers 7.5 urea is a bit on the high side, right? Creatinine 5 years old, that's normal. The rest are normal, right? So just a bit dehydrated. Fine.
Other type of investigation, I would like to do stool full examination.
Yes, fine. Stool examination, microscopic examination. Some you want and also a stool culture, especially if there is blood stain in the stool. So you're worried about dysentery, right? More likely to be bacterial. So fine, stool FME. Sometimes concomitantly you can get kids with lots of worm infestation so at the same time. Have you seen? Better not lah. Like sometimes when you go to the, if you ever get to go to the ward, and if a child with a very bad worm infestation gets AGE, the worms are very clever body, so you get like boluses of worms all in the poop, which is very yucky. But anyway, that's a different thing. Okay. So stool FME fine, stool CNS also acceptable. Those are two different things, right? Microscopic consistency, the consistency, whether they can see any ova and cysts inside or not, whether they can see any protozoa thingies inside or not. The stool CNS. Izati, what will you do after that? Stool, FBC, renal profile, stool. Okay, check already. What else? Virology, final.
Stool virology. Sorry, Doctor.
Anything else?
Anything else? We can do venous blood gases in this patient.
Why?
To check for metabolic acidosis, presence of if the patient have metabolic acidosis or not due to electrolyte imbalance.
Okay, fine. Severely dehydrated patients, we do. Sorry, tak dengar tadi. The last sentence. What was the last sentence?
Saya cakap saya tak jelas.
So if the child is severely dehydrated, then you can do a arterial blood gas. If you do a VBG, all you can comment on would be the bicarb and the base excess levels, which is enough for you to see whether the child has metabolic acidosis or not lah. But more accurate one would be ABG. But then if the child is not dehydrated or just mildly dehydrated, it's not indicated. Okay? Make sense? Anything else? Usually PCO2 and PO2 for VBG, you tend not to look at it because it's not reliable. Okay? If you want a proper assessment of the metabolic acidosis, you need to do an arterial blood gas. But anyway, bicarb slightly low, fine. But your pH is 7.382. Because if you do a VBG, you cannot decide whether it's compensated or not. If you want to see whether it's compensated or not, then you need a proper ABG. What pH? Fine. This doesn't have a base access there. Okay, anything else? Rhoda, anything else you would like to do?
I think no. Because we don't need imaging, right, for this.
Imaging for a patient with AGE with no complications, you don't need any, isn't it? Right? If you have a differential of intestinal obstruction, then fine. Abdominal X-ray followed by an ultrasound might be helpful. Very right. Otherwise, you don't really need imaging for AGE. That's about it, right?
Yes.
Aja, anything else? Dah habis ke slide?
For investigation, done.
Urine, right? You will just want to, everybody was, the person who prepared this was worried about UTI, but obviously no lah. Progression and management.
Okay, so for the management for AGE. This one is
Okay, now this slide, I know you guys got this thing from the protocol. Now the thing is, this table is not an assessment of hydration status. Okay, this table, the big table on the right, is a table used to decide which treatment plan the child should follow. Okay, because if the child is well and alert with no sunken eyes, drinks normally, and skin goes back immediately, is that mild dehydration? No, isn't it? That is normal hydration. True or not? Well, alert, no sunken eyes, drinks normally, skin goes back immediately. That is normal, isn't it? All of you right now can fit under this. Are all of you mildly dehydrated? No, isn't it? Because this title, the title of this, if you look at the original page where this came from, this table has a title. What's the title? I have to go and grab it. Anybody got the page? I want to grab it. That's why it's very important that whenever you have a table, you look at the title of the table, right? Because this table actually tells you where to put the child, in terms of treatment plan, right? This table is not a table to assess hydration status, because basically a child with normal hydration and a child with mild dehydration would be in the same treatment column. Okay? So don't use this. The problem is that some people go and memorize this table. And then when it comes to an assessment of the child, if you just cover the bottom, starting from the purple, gray box, if you just read the first four lines, right? That is normal hydration, isn't it? True or not? Right? Yes. It's not mild dehydration, isn't it? What they are basically telling you is that if this child comes in with AGE and the child is well and alert, or the child drinks normally, you put him in the same treatment plan as a child with mild dehydration. That is what the table is telling you. The table is not telling you that a child who's well, alert, no sunken eyes, drinks normally, skin goes back immediately, has mild dehydration. Because that is not the aim of this table, right? All of you can understand, right, that a well and alert child with no sunken eyes, who drinks normally and skin goes back immediately, has normal hydration. You guys can understand that part, right? Yeah. Yes. Yeah. But because in terms of treatment, a child with normal hydration and mild dehydration, they go in the same column. They get that same treatment. That's why what this table is just trying to say is that if the child is well and alert, but drinks normally, please put him in the same treatment table as a child with mild dehydration. You label him as mild dehydration and you give that treatment. It goes under plan A, right? This is not a table where they say, these are, look, no dehydration, mild dehydration, moderate dehydration, severe dehydration. Because in IMCI, mild dehydration goes less than 5% dehydration, right? The equivalent percentage should be less than 5% dehydration, which also includes anybody with normal hydration, right? So don't go and memorize this. And then when you clock the patient and the child is alert and well wet mucous membrane and everything, and you tell me that the child is mildly dehydrated. No, the child is not mildly dehydrated. The child has normal hydration, right? Because sometimes what happens is that the child's well alert, but got a bit of dry mucous membrane, right? No sunken eyes, drinks normally, skin goes back immediately. So you treat the child in the same treatment column as mild dehydration. So you just give plan A, give fluids, right? And then the child can stay home. Understand? So whenever you take a table out from somewhere, please don't leave out the title of the table, because the title is important. Right? Because it's here, right? This page, isn't it? 359. This is which edition? Third edition. You can use, this is the WHO chart to assess the degree of dehydration and then choose a treatment plan A, B, or C as needed. Because in this WHO, anybody with mild dehydration and normal hydration, but with symptoms, is treated the same way, right? So be very careful when you look at this. So, yep. So basically, it's plan A plus B and plan C. What are you doing? What's that? Recommended of ORS. Okay, fair enough. It's fair enough. There's a formula there, isn't it? Moderate dehydration, how much the child is supposed to drink within a 4-hour period. Okay. Antidiarrheal drugs, no. Antibiotics as well, no, unless it's proven to be bacterial in origin, right? So this part no need lah. ORS, what's in ORS? Have you guys ever seen a packet of ORS?
Yes.
What's in ORS? What's in ORS?
Sodium.
Sodium semua?
Glucose.
Sodium semua?
Bicarbonate.
Huh? What? So basically, you have potassium, you have sodium, you have also glucose in it, isn't it? Right? When you guys manage to go back to the ward again, go look at the ORS station, or ask a sachet of ORS from the staff nurse and look at what is. Okay, so sometimes parents will ask you, is it okay if I just, because ORS doesn't taste very good. The feeling also is not very good. It's like a bit ayau, right? ORS is that type of feeling. So a lot of kids don't like to drink it, and then parents want to give 100 plus. But then if you look at the worry about that. But if you look at the composition of 100 plus and you look at the composition of ORS, it's totally different. So we don't encourage parents to substitute 100 plus for ORS, right? So if parents ask you whether they can just give 100 plus instead, not say no. 100 plus, I think also, the sugar content is very high. I cannot remember really. Aja, anything else?
I think that's all. But for this patient, actually, because she cannot tolerate orally, so they give IV.
IV fluids. That's another reason, like really we cannot tolerate IV, you give IV fluids lah. But nowadays the easy way is to give IV fluids, right? But last time last time when if you ever come across basically cannot tolerate orally, then you give IV fluids lah. But by right, the 75 mils per kilo of body weight every 4 hours, the parent is supposed to sit in front of the patient and spoon it bit by bit until the child can actually tolerate. As was
I think that's all.
okay. Wait, oral. So. Okay, if that's all.
Yes.
Give me a second for checking. Okay, never mind. I gave you guys the link of videos to watch before this now. Have I? Have I given you guys the links to watch physical examination videos before this? Did I? Yes or no?
No.
I think no.
Not sure. Yang tak sini. I think no.
Give me a second. If you want to watch a few
Hi, Basimas. Hello. Is that your mommy? Hi, Mom.
you guys can go here lah if you want to watch videos on how to examine. But it's not very
You want to play a game? Yes, of course you do. Okay, I'm gonna ask some funny questions. Put these here. Oh, and thank you. I nearly forgot about that fact. So, can you point to where your mummy is? Oh, yeah.
Okay, you can go here if you want to watch videos on
Can you show me where your mummy is?
examining.
Can you show me where she is? Can you point at her? Where is she? Where's your mummy?
Wait,
Ask him, man. You want to play a game?
okay, I typed the link is there.
Okay. Can you tell me which one? You tell me.
Okay, if these are mainly for postgrad, but there are parts where they have examination, so you can just watch and see how they do it lah. Especially if you're worried about trying to figure out how to do development, right? Right. So you want to figure out how to do development, you can just look at this. Okay. The recipe parts and the abdominal parts also it's good for you guys to watch, but be mindful that sometimes they skip steps because this is postgrad, so sometimes they don't do everything because they know it's not not that it's not relevant, but there are some things that they can skip. But as third years, you guys should go through the steps one by one until you get the flow before you can learn how to skip stuff, right? So usually this lah. Yeah, you don't know how to how to draw a family chart, etc. Right? So whenever in between watching YouTube, just watch one video and then you can continue watching your other YouTube videos. Okay. Everybody got the link already, right? Just copy the link and then when you have free time, just go and watch. Sometimes I think there's the Children's Boston Hospital also, but I think once it's not every single system. Also you get the Sick Kids Hospital also, but not every single system. You can just take and watch. Most of the time the teaching universities have videos on how to do physical examination. Okay, because you guys are missing out a lot. Copy down the link already now. Copy down already now, and then bye-bye. Okay?
One copy.
Bye-bye. I'm leaving.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.